Okay. Now, in the heart, we also should see the aorta. If it is dilated, remember we have shown you the ascending aorta as an aortic knuckle, the normal X-ray, as well as the descending aorta. And we may see a dilated portion in the descending aorta can be an aneurysm. So aneurysm can also be diagnosed in an X-ray. And remember, aneurysm, if it ruptures, you cannot save the patient. So let's say you had a patient who came for a breathlessness, maybe some lung pathology, maybe a COPD, let's say, for example. And in the X-ray, you diagnose as an aortic aneurysm. Remember, you have saved one life because when aneurysm ruptures, nobody can save the patient. It's not possible. So aneurysms are treated prophylactically before they ruptures. Even if the patient had aortic aneurysm in the ICU, he will not be able to save. It's very complicated because patient will die in 1 minute because of the cardiovascular collapse. So thoracic aorta aneurysm can be seen as an incidental finding, and you only have saved one life if you diagnose this. Also, aortopulmonary window sometimes can be seen as a nodes. We have shown that hilum, enlargement of the hilum, nodes or vessels can be seen very commonly because of any lung infection. Hilar lymphadenopathy, remember, most common finding in COPD, emphysemas, bronchial asthmas, etc. Let me show it to an aneurysm. Ascending thoracic aortic aneurysm. Descending thoracic. It's not ascending thoracic, it's a descending thoracic. If you can see, there's a dilatation, which looks like for example, it can be either left atrial or left ventricular, but 2D echo is going to confirm the diagnosis. Then we ask for a 2D echo, and that confirm that is not the heart, but the aorta in this case. In this case, right. This is what is an descending thoracic aortic aneurysm. It's not ascending, but the descending one. The next thing what we're going to see is a cardiovascular thing is the vasculature. Remember, this is what is only pulmonologist interpret. And today we may be able to at least touch their feet and come back. That is what we can say. Pulmonary vasculature. So in the lungs, we also see the vessels in the lungs. We were not seeing it before. But let's say if you are able to see it, then you are as good as a radiologist. Now, remember we discussed that pulmonary arteries are seen at least the initial part near the hilum. But let's say, for example, we have generalized increase in the vascular markings. That means increase in the bronchial vasculature marking. It can be seen because of the shunts in the heart, left to right shunts. Left to right shunts. Remember, those are the acyanotic shunts. Left to right is an acyanotic shunt. Like, for example, we have VSDs, patent ductus arteriosus, ASDs. All those shunts, VSD, PDA, ASD, we see generalized increase in the pulmonary vasculature. The pulmonary vasculature. Now, if you, I'm going to show it in the X-rays. If it's a generalized increase in the vasculature of the lungs, think about it can be a shunt in the heart. So this particular X-ray, you may order 2D echocardiography to diagnose it. If it is focal or unilateral decrease in the lung markings. Now remember what exactly this shows. If it is focal or unilateral decrease in the lung markings, that means lung must have collapsed, or not the lung but the blood supply I'm talking about, because the vasculature we're talking about, blood supply is collapsed. Why should blood supply in one of the lobe collapse? It can be pulmonary embolism. Remember, logical. So pulmonary embolism can be seen in an X-ray. Now think about it. It's a miracle that if you are able to see those vessels, if there is decrease in the markings in the pulmonary vessels in one of the lobe, think about pulmonary embolism, because embolism will block that particular vessel. See, so how much we can see in the X-ray. We never thought about it before, I think. So if it is, first point was, if it is generalized increase, think about left to right shunts. Let me cover it again. Generalized increase in the vasculature. Think about, we have patent ductus arteriosus, ASD, and VSD. Atrial septal defect, ventricular septal defect. Second important thing in the pulmonary vessels, we have focal or unilateral decrease in the lung marking. Of course, I'm talking about vessels here. So this is pulmonary embolism. It's a medical emergency. Large central pulmonary arteries with sudden tapering. Central pulmonary artery is large and then sudden tapering can be because of pulmonary hypertension. Can be COPD. Can be COPD. Can be COPD. So remember, these are the three things which can be seen in the pulmonary vasculature. In the pulmonary vasculature. You take the screenshot right now. In the pulmonary vasculature. We also see the increased size of upper lobe pulmonary veins. Increase in the size of upper lobe pulmonary veins because of congestive heart failure, with early X-ray sign in case of congestive heart failure. And let me show it to the X-ray so that we can understand it properly. We also look behind the heart because heart is more anterior. We also have some things which are posterior to the heart. So it can be nodule in the lungs. It can also be the hiatus hernia. Sometimes can be seen as a black shadow behind the heart. It's a black shadow because it's the fundus of the stomach going up. Fundus of the stomach has got air. And esophageal dilatation can be tumor or even achalasia cardiac. So not even lungs, heart, but we also are diagnosing the GI disorders in the X-rays, like esophageal atresia, esophageal dilatation, tumor in the esophagus, hiatus hernia, are the GI disorders. Remember, we just have to understand. Remember my first video I had forwarded on the group, that we just understand that what is seen as a black shadow, what is seen as a white shadow, and what is a gray shadow. If you understand this and look at the X-ray, and I can also say meditate on the X-ray. Look at the X-ray and think that what is this white, what is this black, and compare it with normal, and you'll get your diagnosis. This is what we can think, because interpretation is according to what is black and what is white, and what are the symptoms. If you know these three things, you can diagnose many things in an X-ray. Many things in an X-ray. Can do the screenshot right now, if it is possible. Yeah, somebody can share on the group later on. Let me show it to some of the X-rays right now. If you can see, upper lobe venous diversion, patient with a mitral stenosis. You can see curly B lines I was talking about. Let me show it to you if it is possible. It's a left atrial enlargement is also seen it here. You can see there are lines like this, also called as the curly B lines. It is because of the increase in the venous congestion. And the venous congestion is because of the left atrial enlargement. Now, how is it possible? Remember, pathology. Mitral stenosis gives rise to left atrial dilatation. It gives rise to pulmonary congestion. And this pulmonary congestion is a venous congestion. And that is shown as in curly B lines. You can see there is an increased white shadows, if you can see properly. Yes. Look at this particular zones. If you can see there are more white shadows. Is also called as, remember, bat's wing appearance in case of mitral stenosis and pulmonary venous congestion. Pulmonary venous congestion, also called as curly B lines, is because of the upper lobe venous diversion in case of mitral stenosis. Patient with a mitral stenosis. And take the X-ray, take the image right now. We can also see magnification of curly B lines in the same picture. I don't think will be seen properly in an X-ray here. Let me dilate it. Yes, you can see there is white shadows, white shadows, white shadows, white shadows, white shadows. All that white shadows are actually small veins which are dilated. Dilated small veins because of the mitral stenosis, because of the pulmonary venous congestion. And that gives rise to curly B lines. If you can zoom it, you will also be able to find it properly. You can see it in the X-ray. Okay, let me know on the group whether you are able to see it, because it's a shared video. Some things white we can see. You will have to zoom it properly to do. Of course, if you can see, this is what is a breast shadow. This is a female patient. A female patient. Yes, we can also have large hiatus hernia. This is large hiatus hernia. You can see, and maybe this is a barium meal patient, mostly because the hernia looks white in color. It can be barium that is coming up. It can be large hiatus hernia. Can be seen even in the X-ray. This is a barium meal patient. The barium, because this what is coming up is a white. Otherwise, it should be a black. That is coming up. Large hiatus hernia. It's a barium meal patient, right? Now, let's call it a day right now. We're going to continue this. Let me unmute for some time. Let's say, for example, if anybody has any doubt, but there was a lot of disturbance coming up. Raise your hand if you have any doubt. Otherwise, we'll call it a day. Okay. Thank you.